Hello, everyone. Thank you for coming to this presentation today. My name is Joseph Thomas, and I'm here to discuss a case of neonatal Meckel's diverticulum. Meckel's diverticuli develop when the vitelline duct fails to fully atrophy during gestation. Its most classic presentation involves bloody stool and bowel distension. It has an incidence of 2 to 4%, and another 4% of these cases develop complications such as small bowel obstruction, abdominal bleeding, and perforation. Necrotizing enterocolitis, or NEC, is an acute inflammatory disease and is the leading cause of mortality in NICUs around the world. It has a variety of presentations, commonly including poor feeding, vomiting, and abdominal tenderness and distension. In this particular case, a 32-week male infant with unremarkable pre- and perinatal history developed isolated abdominal distension on day of life 11, while on a full TPN diet. They subsequently had diarrhea, emesis, and visible bowel loops on the following day. Abdominal x-ray showed dilated bowel loops and a, quote, bubble lucency, end quote, concerning for NEC. The patient was started on Zosyn at the time, but showed little clinical improvement with persistent distension, pain, and diarrhea. Their labs showed no signs of acute inflammation. At this point, the clinical picture was just not adding up. Normally, there is a symptomatic improvement in patients with NEC within 24 hours of starting antibiotic therapy, but this patient showed none, and in the setting of no markers of acute inflammation or infection. Because of this, the clinicians brought in their differential and consulted surgery. Surgery recommended a barium enema to evaluate for possible small bowel obstruction, and the enema showed just that. The patient was taken to surgery and found to have an acute small bowel obstruction. A resected segment of bowel sent to pathology was found to contain ectopic gastric mucosa, aka a Meckel's diverticulum. We think this case is interesting for a number of reasons. Firstly, Meckel's diverticulum is not commonly seen in neonates. In our literature review, we found less than 5 papers describing neonatal cases. Secondly, this patient's presentation was very vague and nonspecific. And in the NICU setting in particular, their symptoms immediately raised concern for NEC and other serious GI pathologies. Given the high mortality of NEC, the decision to start antibiotics as soon as possible is a good one. In this case, though, there wasn't any improvement in the patient's picture once starting appropriate therapy. The real cause of their symptoms were not being treated, and it would not have been found had the providers not taken a step back and reevaluated their differential for acute abdominal distension with non-bloody diarrhea. We hope that this case highlights 2 things. One, the importance of maintaining a broad differential while correlating clinical state with therapeutic interventions. And second, there is a huge gap in our knowledge of a common diagnosis like Meckel's in this particular age group with neonates. We hope this case contributes to that body of work and further emphasizes the importance of keeping Meckel's diverticulum on a differential with any pediatric patient of any age presenting with GI symptoms. Thank you for taking the time to listen and look at our presentation and poster. I hope you enjoy the rest of the conference. Thank you.